nutrition research so difficult to conduct and interpret? That is what is important. The research design itself is very difficult because there are so many conflicting factors when it is nutrition research. Food itself is complicated because when I say food, the food could be rice, could be vegetable curry, could be all the components of a balanced diet. But the rice itself is different from what is eaten in Kerala from what is eaten in Andhra Pradesh. So how do we compare? So that is what is the complication. If same person like Fida and Fida's colleague is having rice, but the way that food is cooked in Fida's house is different from the other person's house. So that is where food is itself complicated. And then people are complicated also. So you do an intervention, what impacts Fida is different from what impacts to me because we both are two different individuals. Even if you take contemporary individuals, our genetic system is different. So we would respond differently. So then people itself are complicated. Then food and nutrition databases have limitations. So you have to see that the databases is the when I talk about food and nutrition databases, let's take the what is that? The nutritive value book. Okay, the latest one what we have, if you read the introduction, they have, if you're taking the nutritive value of potato, what have they done with coming up with the latest version of the nutritive value in of Indian foods? The nutrition, the composition book, food composition book, they've taken potato from 8 different areas of the country, tested, then come to a common standard quantity. That's why they've given plus a standard deviation, plus and minus standard deviation they've given. So that is what is they're given in the food composition. So it varies. Then reporting nutrition findings sometimes is confusing because what were the bias, especially in your patients? So if you say that nutrition has improved the status of the patient, they will say, what about the medical treatment? Was that a bias of your treatment, of your outcome? So that is what is important that you should take into consideration. The next step, next slide, please. This is a nice paper. It is an open access paper which all of you should read. Intensive Care Medicine Research Agenda in Nutrition and Metabolism. Okay. So they talked about what are the advantages, what are the disadvantages, what are the, things that have been proven, what are things which have not been proven still. Everything is there in this article, wherein they talked about the provision of early enteral and parenteral. What is the advantage? What are the disadvantages? What are the limitations? Routes of early feeding, is it good, bad? What are the limitations? Nutrition risk assessment, GRVs, immune modulating nutrition, and glucose control. After all this, there were some unanswered questions in all these areas. So those unanswered questions can be research questions. So next slide, please. And there were umpteen number of research questions that came from unanswered questions. Of that, they chose 10 most important research questions which you can answer and take it up as research. That was way back in 2017, and I'm sure some of them have already been done to find a solution to it. So these are some of them. They talk about impact of, to study the effects of high and low protein to the outcomes. Okay, so is low protein good or high protein good? And in critical illness or in post-discharge patients. Same thing, high protein in the beginning, high energy or low energy. And then you're talking about muscle mass now. So what is the best method to see the muscle mass composition? And then what is the best assessment tool that you can? They say you can use a prokinetic. So what does it really help in the recovery of the patients? Does it really help in preventing tolerance? So this is all research questions which are there that you can apply to do research. The next. There are some things like say the thing, this nutrition care process in hospital wards. This is something that they have done across all hospitals in Australia. And they came out with this paper where they said, what are the practices done across all hospitals? And what is the outcome that they are looking at? So this is a nice paper that you all can read to find out. You can talk about the applicability of different screening and assessments, but don't do a single center study. Do a large multiple center studies. Then determine the assessment of muscle mass in different categories of patients in the ICU, in the ward. Just choose what is the assessment method and then you can do. Then determine the degree of adequacy among your patients. What is your patient getting? With an oral diet, with an enteral diet, in the ICU, in the ward, and what is the outcome from the hospital? How long was the hospital length of stay with somebody who's eating well and somebody who's not eating well? Then examine the nutrition knowledge and practices levels among different healthcare professionals. You just take the nurses and ask them few questions on nutrition and see how well they know about nutrition. Take your doctors. Ask the same questions and see how well they know about nutrition. So that's about nutrition awareness. That could be a research also. To evaluate the outcomes of functional recovery among patients with nutritional adequacy. Functional recovery is you just do a hand grip. Say for somebody who is really eating well and has a hand grip at admission, and what is the hand grip at discharge? Has it improved or has it gone down? So that's the functional thing. Is he able to sit and stand and walk? How well? With support, without support. So you have validated questionnaires for functional abilities. To study the nutritional status of patients in the outpatient clinic, like the IDRS score is just about the diabetes risk score. Or you just study their nutritional status. They come to the OP, but then they could be malnourished too. Then to evaluate the plate wastage among your patients. Are they eating everything what you've planned? If they're not eating, why are they not eating? Is it because the food is not tasty or is it because they have pain? Because they can't eat, they have no appetite because of pain also. So you ask your patient. Then to evaluate the missed opportunities to initiate an ONS among your patients. You want to give an oral nutrition supplement for somebody who's not meeting an adequacy, but you've missed it. So why did you miss? What are the reasons that you missed? That also can be a research. The next slide, please. In conclusion, research can either be qualitative or quantitative in nature. Research is based on specific research questions, systematic and well-planned methodology. Stay updated with the emerging study designs and statistical techniques used in nutrition research. Apply the findings to real-world situations for our patients and our clients. Dietitians should play a vital role in speeding the translation of nutrition research into evidence-based clinical practice and population-based health efforts. To clear in a selection and description of your research design. Be clear, not too clear, sorry. Recognize the strength and limitations of your sampling approach. Apply appropriate methodologies for analysis. Critically interpret the results. Don't always say that your results are the best. You have to critically analyze it and talk in every angle. The next slide, please. Thank you. I'm a very talkative person, so I go on. Thanks, Vida, for telling me that I have crossed my time.
No, ma'am, not at all an issue. Because thank you so much.
Yeah, we just love to listen also.
Yeah, I
Yeah,
know.
see, I think this is what we wanted in the present scenario, right? We have to apply this, we have to research and apply this in our research things. So this is what we really wanted for this. So thank you so much, ma'am, for explaining everything in detail. And I think like it's not like it's like time going, but we are really focused. And thank you so much, ma'am, for taking your time and efforts to make this happen. So I think now the set is ready for the Q&A session. So if you have, you can just raise your hand so that we'll get the opportunities to have the question session. Anyone?
Research is actually the most toughest thing. I used to hate statistics when I was doing my MSc. But statistics is not about listening. Statistics is about doing and learning. You will know it, you will remember it only when you apply it. And research also, you keep getting ideas when you start off somewhere. And one question leads to the other and it goes on. So probably you should ask me questions and it'll lead. Yeah, that's the upcoming area of work. Everything is linked to microbiome, and you can do. If you take AIG, my hospital, we have a microbiome lab. We do a lot of research in the area of microbiome, and this is, in fact, it is also into the applied practice. What we do for a small set of we do this regularly with the IBD patients, where we kind of test their microbiome, give them a diet plan, and tell them that you come back after 3 months applying this diet plan, and then test their microbiome again. We do that. And we know that microbiome keeps changing once you change the diet for 2 weeks, and then the microbiome changes. So applying the same diet for 3 months, we are sure that the microbiome, and then we connect it to the symptoms. So that's what is applied research all about. And the same thing is with the pancreatic department, where we look at the microbiome with regard to the pancreatitis patients, wherein we, again, same thing as diet, and then we give. So we have different components. Like we've done one research which talks about giving them more of the Mediterranean diets. Of course, a vegetarian Indian diet is also closer to the Mediterranean diet. But when we say Mediterranean diet, sometimes because it's for research purpose that we got a funding and so we did it. Okay. Where we used olive oil, but then not necessary that that does not applies to our community. So that's most important to that. But you can just say eating more of vegetables or a fiber rich, how does it have a role on the improvement of microbiome? Although we know the results, you can test it in your own population. And what we do in our OP, again, it is done for a very limited number of patients, but we still do. We get their microbiome tested and we give them a personalized diet plan. We do that. And where is the problem? We tell them where the problem is, what is more, what is good, what is bad, and what needs to change in their microbiome, and then give them a personalized diet. But this is for a very small percentage of patients that we do because we want to improve that area. And we are getting into what is called as more personalized nutrition. So we are using this microbiome lab to do it for us.
Before moving on to the question, I have posted a feedback form in the chat section. So if possible, everyone can able to update it. It will be really great. Team, any other questions?
Ma'am, regarding like our nutrition researchers, they say that many of the papers we have the study in heterogeneous group, especially when comes to critical care nutrition. So, ma'am, selecting a homogeneous group, ma'am, do you have any experience?
Yeah,
We can say.
see, for example, I did one, see, if you see using the indirect calorimeter, okay? So they say you use it in ICU populations, but then uh, using it in different medical conditions, medical status, you use the indirect calorimetry for research and generate data that you cannot compare these patients. Some patients come with sepsis, some come with trauma, some come after a pancreatic eruption, some come with an IBD eruption. So all these are ICU patients. Okay, and we are doing the indirect calorimeter among all these patients, but you cannot put them under one group. They're all heterogeneous, they are different conditions. So what best solution that I found out is, to prove my point and to know whether it really works or not, we took a homogeneous population. During the COVID, we did indirect calorimetry among the COVID patients. All of them have come with COVID. We know how to grade the COVID patients into, mild, moderate, and severe. And then we took the mild category and the moderate category and did the entire. So they are a homogeneous population. So like that. So if you want a homogeneous population, you select everybody who has sepsis on mechanical ventilation. You want to do something, you take everybody without mechanical ventilation but in the ICU. So it should be that. That is what you need to select patients of that. And then homogeneous means you have, it could be that you're taking only Indians. So that also adds value. Say supposing you have international patients, that patient cannot be a part of your population study. Okay, everybody are you should take patients from medical ICU but not undergone any surgery previously. So that is how you clean your pair. Inclusions and exclusion criteria you have to define and go by that if you want a homogeneous population. You must take one age as one category. So which age group do you want to test your hypothesis? Because they will respond to testing your hypothesis equally. But say supposing you take somebody who is 65 and take somebody who is 26, then there is a huge difference. Then your hypothesis is varied. They are not a homogeneous population because the 65% will be a bias. Say supposing I say the overall muscle mass has reduced, but when I am trying to identify the muscle mass, I cannot compare the muscle mass of a person who is 26 and who is 65 because they are not a homogeneous population. So that's how you need to categorize. You have to say non-pregnant, non-lactating women, no disease, no other comorbidities. Things like that you have to define when you want a homogeneous population.
Thank you, ma'am.
Thank you so much, ma'am. I think now we can move on to the vote of thanks and all. I want to know whether Ansa is here or not.
Hi, yes, I'm here.
Yeah, so now I'll call upon our captain of Meraki. Actually, she's a captain, and she is like basically, I think when a journal club started, she volunteered up to start with this thing, and she only is the brain behind everything. So I would like to call our dearest friend and as well as the captain of Meraki, Miss Ansa Saju, to enter the vote of thanks.
Thank you so much, Kanishma. Thank you so much, Radha ma'am. So good evening, everyone. It's been an enriching evening, and I'm actually pleased to deliver the vote of thanks on behalf of Team Meraki. So first of all, I would like to thank our chief guest, Dr. Radha Chada. She basically covered all the components, types of research, and has given us a better picture about how can we translate research into practice. And personally, it's definitely going to help me take my PhD thesis and make it something more practical and convert it into something that can be used for athletes. And I would also like to thank all the participants for being eager listeners and active participants. So it is not something that has happened overnight. So weeks ago, the wheels began to turn, and it necessitates forethought and like a keen eye for detail. So I would actually like to thank Dr. Sripriya Shadi for being our pillar, for helping us to navigate through our inaugural session. And as Radha ma'am has said, research has to talk. And through the activities of the Journal Club and through CNF activities, I hope and believe that we'll make it happen. I'm actually at a loss for words to express my gratitude to my team. Sripriya ma'am's dedication, their participation and willingness to do things outside their comfort zone has actually helped to make this a success. And like ma'am said, research speaks. I hope through the activities of CNS and Journal Club, we bring forward multiple translational and epidemiological studies that can be converted to practice-based studies, which can further help to develop guidelines and consensus statements. So once again, I would like to thank everybody who is here, who made this event a huge success, and Radha ma'am for being our most beloved chief guest. Thank you so much, everyone.
Thank you so much. I'm really honored to be here and I enjoyed delivering. Of course, I was a little talkative. But then it was a great discussion that it's a very nice idea that you'll have come up with. And I wish all of you all the very best. And I would really give in all my inputs or whatever help needed in the future for y'all to make Meraki more stronger and more larger too.
Thank you so much, ma'am.
It's a
Thank you
great
so much.
better.
Thank you, ma'am.
We definitely hope to have this session with
Yes, yes. Okay.
If possible, yeah, please turn on your camera so that we can just have a screenshot selfie as current trend which we have it. Of course, yes. So if possible, please do. Thank you so much, ma'am. And Tina, ma'am.
Nice to meet all of you all.
Yes, I think Lena, ma'am, I've seen something. Like, I think you're on mute actually. Yeah, sure. Thank you so much. Now, I think let's have a national anthem and we'll wind up the session. Fida?
Yeah.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे, गाहे तव जय गाथा। जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
Thank you, Dr. Radha, for your excellent presentation.
Thank you.
And Dr.
Thank you,
Leena
madam.
Sajjan.
Yeah, thank you so much. It's nice to meet all of you all, at least online. That's the greatest thing, advantage that COVID has done to all of us.
Yeah.
Best advantage that it has given, that we now know perfectly how to do an online program.
Yeah.
Thank you. Thank you.
Thank you all. Bye.
Thank you so much, ma'am. Bye. Thank you for
Bye.
all your participation.
Bye.